Welcome to NEJM This Week. I'm Dr. Michael Bierer. This week we discuss less invasive approaches to guiding coronary intervention, new strategies for preventing kidney cancer recurrence, and head-to-head treatment data in multiple sclerosis. We review advances in multiple sclerosis, follow a diagnostic journey involving gait instability, and discuss correcting false narratives. Perspectives examine physicians and the body politic, chronic pain and OUD, and the often overlooked burden of cognitive symptoms. In a new clinical decisions, a previously healthy 28-year-old man presents to the emergency department with acute abdominal pain, nausea, and decreased appetite. A diagnosis of acute uncomplicated appendicitis is made. You are the patient's attending physician, and you must discuss with the patient the options of appendectomy or non-operative management with antibiotics and close follow-up. After the discussion, the patient understands the potential advantages and risks of both the surgical and the non-surgical approaches to treating appendicitis, but he notes that he is very overwhelmed by having to choose the best approach, and he wants to know what you recommend. You must consider both options. Would you recommend operative or non-operative management for this patient? Vote at nejm.org. Angiography-derived fractional flow reserve to guide PCI by William Fearon from Stanford University, California, and co-authors. Assessing intermediate coronary lesions with an intracoronary pressure wire improves clinical outcomes in patients undergoing cardiac catheterization and percutaneous coronary intervention, PCI. However, clinical use of pressure wire-based physiological assessment remains low. Measurement of fractional flow reserve, FFR, derived from coronary angiographic images alone correlates well with pressure wire-based FFR measurements and may simplify procedures, but its effect on clinical outcomes is unknown. In this international non-inferiority trial, 1,930 patients undergoing coronary angiography in the catheterization lab who were found to have at least one intermediate coronary stenosis were randomly assigned to physiological assessment with measurements derived from angiographic images, FFR angio, or with pressure wire-based measurements. The study found that the angiography-guided strategy involving FFR angio was non-inferior to a pressure wire-guided strategy with respect to a composite endpoint of death, myocardial infarction, or unplanned clinically indicated coronary revascularization at 1 year. Gianluca Campo from the Azienda Ospedaliero Universitaria di Ferrara, Kona, Italy, writes in an editorial that previous trials have shown the superiority of wire-based physiological assessment over angiography alone, whereas randomized evaluations of angiography-derived approaches have yielded mixed results. Against this background, results of the trial by Fearon and co-authors suggest that computational physiological assessment can inform revascularization decisions without compromising short-term outcomes. The broader implication is not a comparison between angiography-derived and wire-based testing, but a shift away from reliance on anatomy alone. Angiography-derived FFR may serve as an integrated first-line physiological assessment during diagnostic imaging, providing an immediate functional estimate to inform revascularization decisions. Pressure wire measurements could then be used at the operator's discretion, particularly when clinical judgment or borderline values warrant confirmation, when additional physiological information, such as assessment of microvascular function, is needed, or when angiography-derived FFR is not feasible or may be less reliable because of anatomical complexity. In this model, computational and invasive approaches would be used in an integrated manner, with the goal being to broaden the use of coronary physiological assessment. The trial by Fearon and co-authors does not serve to displace the pressure wire. Rather, it underscores a broader shift toward physiological assessment as the principal framework for interpreting coronary disease and guiding appropriate PCI. Angiography-based physiology to guide coronary revascularization by Joost Dahmen from the Erasmus University Medical Center, Rotterdam, the Netherlands, and co-authors. This international trial evaluated revascularization guided by vessel fractional flow reserve, VFFR, derived from three-dimensional quantitative coronary angiography without the need for a pressure wire or hyperemic agent, as compared with pressure wire-based fractional flow reserve, FFR. 1,116 patients with intermediate coronary artery lesions who presented with chronic or acute coronary syndromes were randomly assigned to undergo either VFFR-guided or FFR-guided revascularization of the intermediate coronary artery lesions. Among these patients, VFFR-guided revascularization was non-inferior to FFR-guided revascularization with respect to a composite of death, myocardial infarction, or revascularization at 1 year. In an editorial, Yannis Chatzizis from the University of Miami asks, "Is the trial by Dahmen and co-authors practice changing?" It is definitely an important step toward a new standard of care. In an era dominated by artificial intelligence, the trial provides meaningful support for a less invasive physiology-guided strategy that may simplify decision-making in treating the majority of patients with stable or unstable intermediate coronary lesions. At the same time, invasive testing will probably remain necessary in patients with aorto-osteal disease, left main disease, and other complex coronary anatomies. More broadly, angiography-derived FFR, together with non-invasive FFR derived from CT scans, points toward a future in which imaging is no longer descriptive, but rather prescriptive, by integrating anatomy, physiology, and biology to guide safer, faster, and more precise and consistent interventions. In a Science Behind the Study editorial, Amanda Randalls from Duke University, Durham, North Carolina, writes that the trial by Fearon and co-authors shows that the benefits of ischemia-guided PCI do not require direct intracoronary pressure measurements in patients with intermediate lesions suitable for angiography-derived assessment. Instead, they depend on access to reliable, lesion-specific information on ischemic burden, which can be obtained from images already acquired during routine coronary angiography. These findings address a persistent gap in contemporary practice. Pressure wire-based assessment improves outcomes in patients with stable coronary artery disease by guiding revascularization of hemodynamically significant lesions, reducing the composite of death, myocardial infarction, or urgent revascularization, but remains underused owing to procedural complexity and workflow constraints. In contrast, FFR angio is relatively simple and not subject to workflow constraints. It therefore offers a practical means to apply an established principle more consistently. The results reported by Fearon et al. And Dahmen et al. Suggests that the broader use of PCI guided by ischemia may hinge less on improving measurement techniques and more on reducing obstacles to their routine use. Adjuvant pembrolizumab plus belzutifan for renal cell carcinoma by Tony Choueiri from the Dana-Farber Cancer Institute, Boston, and co-authors. Adjuvant pembrolizumab improves disease-free and overall survival among patients with resected clear cell renal cell carcinoma. The hypoxia-inducible factor II alpha inhibitor belzutifan has activity in advanced disease. Adjuvant pembrolizumab with belzutifan may further improve outcomes in patients with clear cell renal cell carcinoma at increased risk for recurrence. In this Phase 3 trial, 1,841 participants were randomly assigned to receive intravenous pembrolizumab every 6 weeks for up to 9 doses, and either daily oral belzutifan or placebo for up to 1 year. treatment with pembrolizumab belzutifan led to significantly higher disease-free survival with a greater risk of grade 3 or higher toxic effects than treatment with pembrolizumab monotherapy after nephrectomy in participants with clear cell renal cell carcinoma at increased risk for recurrence. Rituximab versus ocrelizumab in newly diagnosed relapsing multiple sclerosis by Øyvind Thorkildsen from the Haukeland University Hospital, Bergen, Norway, and co-authors. Imaging evidence of inflammatory activity in relapsing multiple sclerosis has been associated with subsequent disability, and observational studies suggest that early use of high-efficacy therapy may improve long-term outcomes. Anti-CD20 monoclonal antibodies, such as rituximab and ocrelizumab, are among the most effective therapies for relapsing multiple sclerosis. However, data from head-to-head trials are lacking. In this Phase 3 trial, 216 adults with newly diagnosed relapsing multiple sclerosis and recent disease activity were randomly assigned in a 3-to-2 ratio to receive rituximab or ocrelizumab every 6 months for 24 months. Rituximab was non-inferior to ocrelizumab in suppressing disease activity as detected by MRI from 6 to 24 months, with a similar incidence of serious adverse events. Advances in multiple sclerosis. A review article by Stephen Hauser from UCSF Weill Institute for Neurosciences, San Francisco. Multiple sclerosis, MS, is a chronic autoimmune disorder that affects the central nervous system, causing episodes of neurologic dysfunction and often gradual disease progression. In MS, the immune system primarily targets myelin, the protective covering of nerve fibers, leading to inflammation and damage. And then secondary neurodegeneration becomes a major cause of long-term disability. Common symptoms include vision problems, sensory disturbances, muscle weakness, balance difficulties, and bladder dysfunction. Important advances in treatment have improved outcomes in patients with relapsing forms of multiple sclerosis, particularly through highly effective immune-modifying therapies, such as monoclonal antibodies targeting CD20. However, treatment options for progressive forms remain limited, which highlights the need for therapies that can prevent progression and promote myelin repair. Comprehensive symptom management and lifestyle support are also essential to maintaining quality of life and reducing disability. The Daily Grind, a clinical problem-solving by Jasdeep Singh Bajwa, from Rochester Regional Health, New York, and co-authors. A 56-year-old woman was admitted to the hospital for gait instability. 8 weeks earlier, she had noticed a gradual onset of ascending symmetric sensations of painful pins and needles that had begun in her feet. 6 weeks later, she began to have short-term memory impairment, difficulty concentrating, irritability, anorexia, and palpitations, along with paresthesias in her hands that were similar to those that had begun in her feet. She was unable to feel her feet on the ground when she walked, which led to frequent stumbling, and she braced herself against walls for stability. Examination revealed sensory loss in all 4 limbs, impaired vibration and position sense, and an ataxic gait. A key clue emerged when records from a recent hip revision surgery showed implantation of a cobalt chromium femoral head after failure of a long-standing hip prosthesis. Extremely elevated blood cobalt and chromium levels confirmed systemic cobalt toxicity caused by accelerated wear of the implant. The patient underwent urgent revision surgery to remove the cobalt source and received chelation therapy. Her cognitive symptoms and gait instability resolved, though she had persistent neuropathic symptoms. Correcting false narratives. Indispensable Latino Contributions to U.S. Population Health, a perspective by Vincent Guillermo Ramos from the Johns Hopkins School of Nursing, Washington, D.C., and co-authors. Latino people in the United States are indispensable to the country's prosperity and future. But political discourse that increasingly degrades this group has fostered anti-Latino attitudes in segments of U.S. society, as well as in media and other institutions. In this climate, factually inaccurate anti-Latino narratives obscure and downplay Latino contributions to U.S. society and legitimize discriminatory policies, including surveillance and profiling of Latino people by law enforcement. These trends are harming Latino people's health, both directly and by fostering harmful social determinants of health. These authors challenge inaccurate narratives by offering a more factual depiction of essential Latino contributions to the economic, social, health, and political sectors. For example, 79% of Latino people living in the United States are actually U.S. citizens by birth or naturalization. Latino people are an economic superpower and advance U.S. prosperity. The U.S. healthcare system is subsidized, not drained, by undocumented immigrants, and a record 16.6 million Latino people legally voted in the 2024 presidential election, making the Latino community's electoral participation a decisive factor in some key states. These authors also examined the harmful effects of the false narratives on Latino people's psychological well-being, physical health, and maintenance of a strong healthcare workforce. Declarations of Independence, Physicians and the U.S. Body Politic, 1776 to 2026. A perspective by Scott Podolsky from Harvard Medical School, Boston, and co-authors. 5 of the 56 signatories of the Declaration of Independence were doctors, a high watermark in the history of medical representation in American political leadership. These physician signers epitomized the multifaceted professional identities of doctors in this era. Not only, and often not primarily, medical practitioners, they played many roles in their communities. Of the Declaration's physician signers, Benjamin Rush was by far the most celebrated. A founding father of America and American medicine, Rush became an early campaigner for American independence, encouraged Thomas Paine to write Common Sense, and crossed the Delaware with Washington's troops. Medicine was a discipline deeply concerned with the social as well as physical well-being of the country. But despite the prominent positions Rush and the other physician signers achieved in American political history, subsequent generations of physicians have largely abandoned these roles. Between 1789 and 1889, a total of 4.7% of the members of Congress were physicians. Between 1889 and 1982, the percentage dropped to 1.1%, despite the rising status of physicians in American society. Physician representation in Congress held steady at 1.1% from 1960 to 2004, even as medical concerns and health policy, such as the passage of Medicare and Medicaid and the advent of managed care, commanded increasing national attention. Key players in setting national health policy have not been physician legislators. As our nation continues to grapple with issues for which medical expertise is sorely needed, physicians may wish to reconsider their independence from national politics. Opportunities to combat the chronic pain opioid use disorder syndemic, a perspective by Zhuyin Su from the National Institute on Drug Abuse, Bethesda, Maryland. More than half of people with opioid use disorder, OUD, also have chronic pain, which may be caused by injuries or chronic health conditions. Yet pain remains undertreated in this population. Although evidence-based treatments are available for both conditions, such treatments are rarely integrated. Recent changes in Medicare policy for chronic pain management and in OUD treatment regulations offer pathways for addressing these barriers that could advance access to care, prevent overdoses, and improve people's quality of life. For example, pain isn't routinely assessed in most addiction medicine settings, but routine use of validated, comprehensive pain assessments, such as the Pain Enjoyment of Life and General Activity, PEG scale, could enhance clinical attention to pain severity, quality of life, and functioning. The Substance Abuse and Mental Health Services Administration has permitted some patients to take methadone doses home from treatment programs, and lockboxes can mitigate the risk of diversion, enabling patients to split doses. And Medicare recently issued collaborative care billing codes for chronic pain that permit reimbursement for 30 minutes of care coordination, with the possibility of billing for additional 15-minute increments within a single calendar month. Furthermore, continuous education for clinicians and workforce expansion that includes peer specialists are promising approaches to help overcome barriers to integrated care. The Invisible Load of Cognitive Symptoms, a perspective by Jan Stabberud from the University of Oslo. On paper, the patient looks fine. Her MRI is unremarkable. Her laboratory values are within the normal ranges. She arrives at the clinic on time, where she speaks fluently and smiles at the right moments. She performs well enough on a brief cognitive screen to reassure the clinicians in the room and even, for a moment, herself. But then she starts describing her typical day. She keeps forgetting why she opened her laptop. She rereads the same paragraph multiple times without retaining anything. She loses the thread of a conversation easily, especially if two people speak at once. She can manage one appointment, one conversation, one errand, but not a series of them. By afternoon, her mind feels like an internet browser with too many tabs open. Nothing crashes instantly, but everything slows, stutters, and eventually freezes. The most disabling symptom, she explains, is not dramatic memory lapses. It is the constant, invisible effort required to function. The internal checklist running all day, the mental sticky notes she must rewrite repeatedly. Such failings are the invisible load of cognitive symptoms, reflecting disability that often eludes medicine's usual metrics. One way to close the gap is to underscore for clinicians and clarify for patients and society the difference between cognitive capacity and cognitive bandwidth. Many health conditions reduce bandwidth before they reduce capacity. Assessing someone's bandwidth requires asking different questions that validate the patient's experience while remaining clinically rigorous. Medicine cannot screen its way out of the problem of shrinking cognitive bandwidth, but clinicians can respond more compassionately and constructively by acknowledging the symptoms, systematically evaluating contributors, offering pragmatic supports, or considering a referral for more comprehensive evaluation. In our Images in Clinical Medicine, a 40-year-old woman presented with a 1-month history of fevers and 3-week history of swelling in her right armpit. Ultrasonography showed enlarged lymph nodes with an adjacent fluid collection. The patient recalled being bitten by a stray kitten 2.5 months before presentation. PCR and IgG serologic testing confirmed a diagnosis of cat scratch disease. In another image, a previously healthy 4-year-old boy presented to the emergency department with a 1-hour history of leg pain and an inability to bear weight on his left side. While jumping on a trampoline with his father at home, he had leaped higher than usual, landed on his feet, and then felt the leg pain. A diagnosis of a trampoline fracture was made. Trampoline fractures in children typically manifest as transverse proximal tibial fractures owing to compressive axial forces on the bone while bouncing. The risk of these injuries increases when a heavier person is also jumping and generating increased recoil of the trampoline. Read more from our issue at NEJM.org. Let us know what you think about our podcast. Any comments or suggestions may be sent to audio@nejm.org. Thank you for listening.